can I get some large Gelpies, please? Thank you. Hi guys, this is Charles. I'm one of the surgeons at the Animal Emergency Center in Melbourne. Today we have our linear foreign body of the week. So we've got a cat that's presented with vomiting, seen by the emergency service and then ultrasounded by our internal medicine specialist. And he found what he thinks is a linear foreign body, and so we're going to explore and see what's going on. If you haven't already done so, please subscribe to our channel and make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So here we go. It's like Christmas. Perfect. Yeah, please, thank you. So, as usual, we have Chad, our internal medicine specialist, hovering outside the theater because he wants to see what we found. And he's doing active learning, which is when you have a theory and then you test it and then you revise your theory so that he gets better and better at identifying linear foreign bodies. Can you open that for me, please? Hi, Gainesville, Florida. I am a gator. I'm not sure if you're aware. I absolutely loved Gainesville when I was there. All right, so there's our linea. You can see that nicely. I might actually try to zoom in a little bit more. There we go. We have our new high-res camera, so 4K. I think it's already no, so that's a replacement tip for that, so that just comes out. A little bit off midline, and then we can see our falciform. I just feel a bit nervous when Chad is waiting. I feel like I have to hurry. Just move that Omental out of the way. Okay. All right, so a segmental piece of jejunum that was inflamed, and then something popping through the pylorus. That's right, I'll just cut that off. So we've got our liver looking very healthy. And where did our, oh. Excuse the green gloves. They're making me very uncomfortable. I'm not used to looking down at my hands and seeing Shrek. All right, so even though we know we've got a foreign body, we are going to do a complete exploratory. So looking up at the gallbladder, the diaphragm looks nice and healthy. Gallbladder is easily expressible. Palpate the stomach. Make sure there aren't any other foreign bodies in there, and we'll check the pylorus because Chad thought he saw something maybe going through the pylorus. It feels a little bit funny here, maybe a little bit thickened. We'll run the duodenum here. Coming around the caudal duodenal flexure, you can see that duodenal colic ligament right there. Coming into the jejunum. Looks a little bit, I can feel something in there. Yeah. Yeah, I feel a foreign body in there. Just hold on to that so I don't lose that bit. We'll keep running the intestine all the way down. Thing looks not too inflamed. There's certainly no evidence of peritonitis. We've got our cecum here, some maybe moderately enlarged ileocolic lymph nodes. Colon looks good. Looking at the right kidney, caudate lobe of the liver. Can't see the right adrenal gland, which we would expect not to be able to see. The spleen, looking at the left kidney, you can see the left adrenal gland right there with the frontoabdominal vein on top of it. All right, so, Kate, you're not Chad. All right, a sneaky one. Yeah, I think so. All right, so we will get some saline, please. Yes. Signalment on the cat. Signalment, how old's the cat?
8 to 10 months.
8 to 10 month old cat, yeah.
No previous surgery, but no indiscriminate after.
Male or female? Doesn't have a uterus.
That one doesn't go up to the stomach.
I couldn't feel it. It might. There certainly doesn't appear to be any linear foreign body kind of effect. Yep. Yeah. All right. So I'll just pull out my Gelpies temporarily, just to try to reduce drying of the intestine and maybe reduce contamination a bit as well. Oh, a nice warm saline. I have to go to the bathroom. All right, so we'll put that on there, and I'll get another little bit over here. And this is to keep the intestine moist, and also to keep the cat warm. All right, so we'll do, I don't feel a lot of fluid in there. Very interesting. Can I get some 4O PDS, please? Yes, please. Thank you. Yes. Let's see what I'm going to do here. Let's grab a hemostat, please. Yep. Grab another hemostat. Thank you. All All right, so now we'll just lift both of those up like that.
And you said you always make your incisions transversely, don't you?
I try to. So it looks like a hair type thing.
Yeah, it's fine.
Yeah.
Roxanne said.
Okay, so it's a bit longer than what we anticipated. We're getting a little bit of plication of the intestine. Just see if I can get it out distally first. Okay. What's that? Yeah, quite a bit.
Yeah. Is that a ribbon?
Okay, so ribbon looks like. All right, so all in one piece. See if you guys can see that. Okay, so we'll get rid of that. Yeah, it's quite long though. I could feel it stringing quite a distance. Yes. Good job. Thank you.
Do you just do them uninterrupted?
I do continuous. All right. Yeah, I'm just going to put an interrupted suture at this end, which will be our stay suture. Just switch over from one of the hemostats. Just grab either one. Grab onto that. Okay. We'll move that back across here. I'll recenter that in a second, guys. Do not fret. Move that back across. All right, so now what we're going to do, you keep holding onto that, and you'll hold on to this, just like that. All right. All right, and put a bit of tension on it. More tension. Yep. A bit more tension. Bit more tension, bit more. And I am wearing loops for this, partly because I'm old and farsighted, but I think that it does really help me with accurate suture placement.
You're just doing single layer positioning?
Yeah. And then I don't leak test, but I will test with hemostats, probe with hemostats, to make sure there's no space. Small intestine's a low pressure system, and so if you put it under high pressure, you can make anything leak. The other key thing is making sure that I keep tension on the suture as I'm suturing, just to keep the sutures from loosening further back. All right, so then we'll go back and have a look at our suture line, make sure nothing is obviously loose, make sure there are no obvious gaps, and then I'll take a hemostat. Let's get the sharpest little hemostat we've got in the pack. And I'm using 4.0 PDS. Yeah, there's no way anything's coming through there. All right, so comment about changing the camera direction. I always say if only one of us can see, it should probably be me. All right, so then we're going to omentalize this. And a lot of people will just drape it on. I usually suture it. All right, can I get some more 4.0 PDS, please? All right, so, and I don't mind if I go full thickness on my omentopexy. I don't intentionally go full thickness, I'm just trying to tack. But if I do go full thickness, we're going to leave this on long, Tom.
Okay, sure.
If I do go into the lumen, it's fine. Thanks. can run that for me, please. And if I haven't answered your question, I apologize. I have not been looking at the screen. It's all good?
Oh, sorry.
You all right? But I will go back at the end of the live stream and make sure that I've answered all the questions, so stay tuned. Okay, can I get, actually go ahead. That saline is probably warm enough. All right, so we'll just get can I get some 3.0 PDS, please? Use my gilpies to kind of retract the abdomen open, and we'll lift that up a bit. And suction on. No, nothing. No, still nothing. Nothing coming out of the wall. That is weird. There's suction on the, like on the gauge, there's suction there. Might need to get it. Yeah, we're just waiting for a portable suction unit. So the cat's going to be eating as soon as it wakes up. So I don't believe in fasting these guys at all. Gee, that camera is clear. I have to say I'm very happy with that.
Yeah.
Risk of leakage from this surgery is about 5%, I would say. That's better. All right, so what's that? No, it's good. All right, just lift up on that for me while I get started on my linear suture. And on the linea, I do simple continuous, always. And quite long on that. Yep. I do use AI for my records. I use Heidi Health, which I love. I've been using for about probably 2.5 years. Changed my life. I see you're writing from Charleston, South Carolina. I lived in Charleston for a long time. And I worked for Carolina Veterinary Specialist for a little while. I went to Portugal School. My mother used to live on Kiowa Island. I got married in Charleston. And it's one of our favorite holiday destinations. Had the recovery breakfast on Kiowa Island in South Carolina. Let me know what you think of the new camera, if you can see a difference in the quality of the stream. I have a few more surgeries today. I'll try to live stream at least one of them. So I've got a CT scan and anal sac adenocarcinoma. And the anal sac is on the left side. We'll take at least that anal sac mass out. We may also have to take out sublumbar lymph nodes if they're enlarged. And then I've got a lateral thoracic soft tissue sarcoma, which is subcutaneous, so it's not going through the chest wall. So stay tuned. Stay awake if you're in America. It'll be worth it. Quite long. Thank you. I beg your pardon? It doesn't matter, whatever you guys think. If you guys want to do both, we could start the CT now. So BOOF is the anal sac adenocarcinoma. Yeah, this is a brand new Canon R6 Mark III, which is a really high quality professional grade mirrorless camera. It's used actually for professional photography, but the video happens to be as good as anything you'll ever get. So my intent with getting this camera was that I could do freeze frames anywhere in the video and get a photographic quality image, which is what I think we've achieved. So that's exciting for me.
You're just kind of every now and again tacking down to the abdominal wall to reduce like dead space.
Yeah. kind of every second, third bite kind of thing. Bless you. So you only need external rectus fascia to close when you're off the linea. There's no reason to get the internal rectus fascia or the peritoneum. And in fact, it's not counterintuitive, what's the word? Contraindicated. Because by suturing the peritoneum, you actually induce more adhesions. So I did 3 OPDS in the linea, 3 OPDS in the sub-Q, and I'm doing 4 OPDS in the intradermal. And we have used bupivacaine. We've done a line block on the incision preoperatively. So now both my ands are deep, so I'm going to have to go deep to superficial. And then I'm just going to run, because I've got almost no space here, I'm just going to run a horizontal kind of running suture. And again, stay tuned because I will go and answer any questions that I haven't answered when I'm finished. Thank you. It's nice suturing with loops on because when you take your loops off, it looks so nice and neat. Your bites are much closer together and much more accurate than they would be if you weren't wearing loops.
It's like the operating microscope.
Yeah.
Reveals every shortcoming.
Yeah, like I've done arthroscopy where when introducing the instrument into the joint, you feel like you've taken a huge chunk out of the cartilage, and then you open it up and realize that you can hardly see it. Tom, I reckon live streaming would go really well at your guys' place with all your operating microscopes and stuff. I bet that would be really cool. Present it to Chloe and Anu, and I can help you guys set up. You can even, I can give you admin privileges on my channel, and so you don't have to reinvent the wheel. if they're interested. How often does something go wrong during ophthalmic surgery, where in the middle of surgery you're like, uh-oh?
I wouldn't say very often. It really depends on what we're doing.
Yeah. And I think, at least with surgery, I think it's important for people to see things that can go wrong and then how you rectify it. And how you keep your cool and solve, problem solve. And it certainly isn't for everybody, but I really enjoy it. So now I'm making all of my ends deep again in order to bury that knot. Whoops. I'll just put a little simple interrupted or cruciate over that. I had 3 throws before it broke, so it should be fine. All right, so let me just go back. I use a taper needle. I never use a reverse cutter for anything. Unless I'm doing, like skin sutures, I'll do a reverse cutting, but pretty much everything else I'm going to use a taper needle. I'm just going back through the questions now. Good morning, Qatar. So next surgery is an anal sac adenocarcinoma that we're about to do a CT scan on. I don't have any videos of me spaying cats because I don't spay cats. That's always a GP thing, and so I haven't. You don't want to see me spaying a cat. Post-operatively in this cat, we'll give meloxicam and probably buprenorphine, maybe methadone in hospital and then buprenorphine to go home. And I always do a transverse incision because I think that it compromises your luminal diameter less. So pylorus was just that, good question, thanks for bringing that up. That was just the linear foreign body extending all the way back to the pylorus. So I moved to Australia in 2004. My wife was Australian, and we just felt like the lifestyle was better here, and we just would rather bring our kids up as Australians than Americans. So, opening the intestine, I would avoid opening the intestine if I could. So I'm not sure exactly how else I can answer the question. If you have multiple perforations, you are going to have to do all of the, you probably resect some bowel, resection and anastomosis and that kind of thing. But yeah, I mean, I will open the large intestine if I have to. Hi, Nigeria. Hi, South Korea. Our cautery cutting device, we sterilize using ethylene oxide. You can also use plasma gas. Some people use cold sterilization, recognizing that it's mostly going to be used for soft tissue surgery. Hi, Philippines. Hi, Steph. Hi, Buenos Aires. Hi, Arizona. Canada was not anchored orally. Argentina. Canada, California, Gainesville, California, Brisbane, Orlando, and Dubai. All right, back down to the bottom. So there is a chance of leakage into the abdomen. It's about 5%. And this intestine looks really healthy. I did a very small enterotomy. I did a Omental patch, so I think that it's pretty safe. You're welcome for the stream. Hi, Mexico. So if you're doing a subcuticular or intradermal, you really shouldn't have to do anything on top of that. All right, so we'll go ahead and wrap that up. Thanks a lot for watching, and we'll see you hopefully again in the next hour or so.